Thank you to ECR and leadership for the opportunity to present today and have this special session. We're quite excited to share the information with you about the Lancet Oncology Commission. So we know that previous commissions highlighted socioeconomic benefits of investments in cancer surgery and radiotherapy and widely disseminated information at WHA and UN high-level meetings and others. And that was subsequently followed by unanimous adoption of the Resolution on Cancer Prevention and Control. This was an extremely important step. In November of 2017, a meeting at the World Cancer Leaders Summit in Mexico City, initiated by Miriam Michael, was the first real green light, and David, as usual, had vision and supported this initiative. Concept note and white paper were developed, and then a meeting was convened in February of 2018 by the IAEA and Diana during ECR to launch the concept and invite partners. This was the real beginning of what you're going to hear about today. In July of 2018, we had our first formal commissioners meeting at the IAEA headquarters, and Hedi Risak was chosen as the lead commissioner. And of course, she is quite a force and managed to make this happen within the limited time frame that we had. Establishment of the steering committee and secretariat meant that we had communications ongoing between all of these players and commissioners, as well as data collection and drafting. The recruitment of societies into this effort was led by Hedi and myself. And subsequent to that, there were several meetings that were done through RSNA, ECR, SNMMI, and RSNA again in December of 2019. The aim of the Commission was to provide data and guidance, and this would act as a catalyst for sustainable change in medical imaging and nuclear medicine for cancer management. So there had to be global data collection. There had to be estimation of cancer mortality, which can be averted by upscaling imaging in combination with treatment. There has to be an investment case made, and there have to be actions outlined toward realizing the benefits, the health and economic benefits of upscaling. So here we see the IAEA data collection mechanisms, whether it's through our projects like TC, whether it's through human health, nuclear safety, all of these with meeting reports, missions, country program frameworks, national liaison authorities that are, representatives from the government, staff duty travels, and then we have, of course, regulatory authorities and databases that we can also use. So the data went into the database, Imagine database, and as you can see, a significant amount of that data was through the International Atomic Energy Agency data. There was some data given from other or extracted from other organizations, as you can see. And this data collection started in 2006 for nuclear medicine and 2014 for radiology. The image methodology was basically to seek the best data for each country and territory. And one example is using, for example, World Cancer Report that looks at mortality and population, etc. And then this was through, of course, IARC. This is another example of using the data that's available through the World Bank, for example. And in this case, we have data about population, income group, GDP, life expectancy, health expenditure, and many others. So the Imagine data collection was able to show us very clear differences between high-income countries and others. And also, we could see the number of CT scanners, for example, that are available in the country per million. So it gives you a very good overall picture of what is happening. So what did we find in terms of radiologists per country? The same thing. There was a great variation by country. And of course, PET scanners were even more significant changes and numbers. We also had information about the price of equipment based on equipment purchased by the IAEA within the previous 2 years. We had information on age, profile, renewal. We had guidelines and relevant data from non-state actors like COSIR. So why did we do that? Well, our role at the IAEA, basically Division of Human Health, is to strengthen the capacity of countries to address health conditions through the application of nuclear-related techniques. That's what we're all about, and that includes radiology and nuclear medicine. If we look at our projects, we'll see that the majority of our projects are in human health. It's the largest number of projects that we have. And we align our projects with member state priorities, so there is political support. And other important issues to mention is that we have country program frameworks where the national priorities are there, and we base our technical cooperation projects on those, and also regional agreements and other opportunities. You can see that the reach of the TC projects is quite significant throughout the world. And not only that, but even if you look into the details, 51 million in procurement, 2019 alone, 82 million in the fund for other support. We have participants in training courses, expert and lecturers, training courses, 206, 2,000 fellows and scientific visitors, and from all over the world, as you can see. So yes, our three main areas were known for safeguards, safety, and security, but nuclear sciences and applications in human health is a significant part of what we do, as you saw from the diagram. So the IAEA looks forward to partnering with you towards the goals of this commission. We have mechanisms in place to be able to take action and support the actions that were identified within the Lancet report. So thank you very much for listening.
My name is Andrew Scott, and I'll be presenting on global utilization of imaging and nuclear medicine in oncology. As outlined by Dr. Abdel Wahab in the prior presentation, accurate numbers of equipment as well as workforce at a global level for imaging has not been previously established. Through the Imagine database, we have been able to assemble information on the numbers of scanners per million population at a global level and have been able to stratify this according to income groups. In the table on the right-hand side of this slide, you can see for CT scans, the median number of scanners per million population was found to be 20.5 in high-income countries, with an interquartile range of 14.4 to 32.7. When we then looked at the numbers of scanners in upper middle-income countries, the median number reduced to 7.8 per million population, but in low middle-income countries down to 1.4 and down to 0.4 in low-income countries. A similar trend was seen for MRI scanners, with a median number of 12.6 per million population in high-income countries, with the interquartile range of 8.5 to 19.2. But the median number per million population in upper middle-income countries went down to 3.4, in low middle-income countries 0.4, and low-income countries down to 0.1. For SPECT, median numbers per million population of 5.4 in high-income countries, only 0.9 per million population in upper middle-income countries, down to 0.1 in low middle-income and 0 in low-income. And for PET, which is primarily used for oncology patients, the median number in high-income countries was 1.2, with an interquartile range of 0.6 to 2.5, down to 0.2 in upper middle-income countries, and 0 in low middle-income and low-income countries. So it's very clear that there are marked discrepancies in the median number of scanners depending on the income groups of countries which were evaluated. And there's also quite substantial variations in the number of scanners within those income groups. This is displayed in graphical global representation in this slide for CT scanners. We can see when at the high number per million population of 20 to 30, in the darker shades of green, we can see this principally in high income countries in North America, Europe, Korea, Japan, and Australia. but the low numbers of CT scanners, which are also used for other health conditions, is very low in Africa, in Asia, and in parts of Latin America as well. This is more obvious for MRI scanners, where you can see that there are markedly reduced numbers of MRI scanners and thus availability for cancer patients in Africa, extensively throughout Asia, and also in parts of Latin America as well. This trend is also seen for SPECT scanners, with again the lower numbers demonstrated in yellow in Africa, Asia, Latin America, and some countries in grey where there are no scanners reported to exist at all. And with PET, this is even more marked, where grey indicates no PET cameras, and the lower numbers are in the lighter shades of green, and the higher numbers mainly seen in high-income countries with the darker shades of green. In the context of workforce, the global survey has shown for the first time the distribution of radiologists at a global level. In the table on the left-hand side, you can see the median number of radiologists per million population is 93 in high-income countries, with some variability into quartile ranges from 51 to 129. This reduces to 30.6 in upper middle income countries, 6.9 in low middle income countries, and down to just over 1 per million population in low income countries. Again, demonstrated with the grey and yellow colours for countries, particularly in Africa and Asia, very low numbers at a global level. And for nuclear medicine physicians, this is even more marked, where there are many countries where there are none at all in Africa and Asia, and very low numbers in other countries in these regions, with a median number of 6.5 per million in high-income countries, 1.5 upper middle-income countries, and down to 0.1 or 0 in lower middle-income or low-income countries. We do know that nuclear medicine studies are reported in many countries by radiologists. However, it does indicate the workforce gaps which exist in low middle-income countries in this particular area of imaging. So in the context of gaps identified as part of this Lancet Oncology Commission, it's clear that imaging equipment availability is substantially reduced in low-income and middle-income countries. We also know that the infrastructure that's associated with the scanners and radiopharmaceutical access for SPECT and PET-based studies are also barriers to delivery of imaging to cancer patients. And there are also differences in equipment availability between countries within income groups. However, the median numbers of scanners can be used as a very important baseline to identify what should be implemented, along with clinical practice guidelines to provide adequate imaging support for the treatment of cancer patients. We know that a well-trained workforce is essential. And so radiologists, nuclear medicine physicians, as well as radiographers, nuclear medicine technologists and scientists are needed to be able to provide these imaging services. And the lack of a trained workforce does impact on quality and service delivery. We also noted there is a lack of country policy guidelines on appropriate levels of imaging and nuclear medicine facilities and workforce required, and the data which we have been able to obtain will be able to assist with the establishment of the appropriate levels that are required for effective delivery of imaging services for cancer patient treatment. And it's also very clear that training programs and online resources play a vital role in workforce education. And although there are some of these programs available for low and middle income countries, more needs to be done. There are technology advances which have emerged in the last 5 years, particularly, which are aiding in the availability of imaging in low and middle income countries for cancer patients. Digital connectivity is a key component of this, where images can be acquired and transmitted both to local cities, within a country, and even between countries for interpretation or for additional input into evaluation. It's essential that we have clinical information on patients in order to be able to appropriately interpret imaging studies. And so electronic medical record implementation is key. And we know that this is variable, but increasing in implementation in low middle income countries. Only 15% of low-income countries at present have a more generalised electronic medical record system. But open source approaches are being developed, and these will assist with establishing better connectivity to clinical information and the imaging studies in the future. Low-cost point-of-care devices, such as this ultrasound transducer on the right-hand side of the slide, which can be connected to a mobile phone to be able to review the images, report the study, or transmit the images for subsequent review at a distant location. And for the more sophisticated scanners like CT, MR, SPECT, and PET, solid-state systems and modified gantries are being developed for cost-effective mobile solutions. And finally, advances in digital connectivity and artificial intelligence will also play a role in improving the workflow, the accuracy and the quality of the data which is interpreted. This slide provides a schematic of the workflow where artificial intelligence input can assist right from when a patient presents to the imaging department, where they can be identified, they can be linked to the referral and their clinical medical records. The scans themselves can be protocolized according to the clinical question being asked. We can even use biosensors and AI to assist with the acquisition and standardization of the scans which are performed. And these algorithms can also assist with post-processing, both to develop the most relevant imaging data sets that are required, as well as performing initial reviews to identify abnormal findings, which can then be looked at by the radiologist or nuclear medicine physician to be able to interpret the scans, to be able to generate a report and transmit this to the referring physician, and then engage with the appropriate clinical groups, often through multidisciplinary meetings, to be able to give information which can then be used to inform the treatment of the patient themselves. So clearly, digital connectivity and artificial intelligence will have an increasingly important role in the provision of imaging services for cancer patients in the future. Thank you.
Hello, I'm Rifat Atun. I'm Professor of Global Health Systems at Harvard University. I'm also one of the three lead authors on the Lancet Commission on Medical Imaging and Nuclear Medicine. I want to share with you the analysis of global costs, health benefits, and economic benefits of cancer imaging. The antecedents to the study date back to 2010, when we developed an investment framework for investing in HIV, tuberculosis, and malaria to demonstrate benefits of investing in global health and to mobilize funding for the Global Fund. Since then, we've developed these methodologies and have applied them in multiple settings. In 2010, we, with my colleagues Paul Farmer, Julio Frank, Felicia Knoll, and Larry Schulman, we published a paper in the Lancet and called for an expansion of cancer care and control in low and middle income countries. In this paper, we called for an investment in cancer care and control, arguing that this would yield substantial benefits to the countries. Now, we made an investment case, which is critically important because an investment case for cancer provides an organizing principle for a core set of actions. It changes the narrative from cost to return. It emphasizes health and economic benefits. It also provides a clear time horizon for action, costs, and returns. We have applied these principles to two Lancet commissions, the two Lancet Oncology Commissions. The first on expansion of global access to radiotherapy, and the second, published in March last year, on the sustainable care for children with cancer in low and middle income countries. We further developed these methodologies and applied them in the Lancet Commission on Lancet Oncology Commission on imaging for cancer. These methodologies published in two papers in the Lancet Oncology. Essentially, we developed a microsimulation model of stage-specific cancer survival in 200 countries and territories for 11 cancers. These cancers account for 60% of the total cancer burden globally. We estimated country-specific availability of chemotherapy, surgery, radiotherapy, and targeted therapy, as well as imaging modalities. We calibrated the model to reported survival estimates using data from Concord 3 and estimated 5-year survival for diagnosed cancer in each country or territory for the period 2020 to 2050. We then estimated costs, survival gains, and deaths averted when scaling up individual treatment and imaging modalities in isolation or in combination. We then computed economic benefits of improving cancer survival by using value of life approach, also called the full income approach. This approach recognizes intrinsic societal value of a life year gained and not just the productivity. We then compare the costs and economic benefits of a scale-up to a counterfactual of no scale-up. And we then projected the return on investment for each country. We also projected returns by geographic region and by country income group. I'd like to recognize the excellent work undertaken by my colleague Zach Ward in developing the model and leading on the data analysis. Our results show that the projected deaths averted and life years saved are very, very substantial when we look at these by different scale-up scenarios. So globally, if we were to scale up imaging only in 2020 to 30, the number of deaths averted would be 2.5 million, accounting for about 55 million projected life years. With treatment only, the number would increase to 4 million, but with comprehensive scale-up, the number would increase to a very substantial number of 9.5 million cancer deaths averted. This translates to 232 million projected life years saved. Discounted at 3% discount rate annually, this translates to 133.7 million life years saved. Most of the gains will come from Africa and Asia. With comprehensive scale-up, the number of deaths averted in Africa would be 2.5 million, and in Asia, 5.3 million. These translate to 34.6 million and 76.9 million life years averted, respectively. So very substantial numbers. If we look at the cancer deaths averted by level of comprehensive scale-up by country income group, we can see that in this figure, most of the scale-up, as discussed earlier, will be in low and middle-income countries, but the major benefits in low-income countries will be achieved once reaches a scale-up level of 60% or more, where we can see a sharp uptick in the number of deaths averted. Looking at the cumulative net benefits selected scenarios by country income groups, we can see that for each income group, low income, middle lower income, upper middle income, and high income, we can see that compared to the baseline, scaling up of comprehensive set of interventions compared to imaging only or treatment and quality of care is actually very, very substantial. So there's a compelling case for scaling up a comprehensive set of interventions, not just imaging or treatment or quality of care. In fact, if we look at the net benefits, we can see very substantial benefits realized in all countries with comprehensive scale-up at different levels, whereas in upper middle income, high income, and in lower middle income countries, the increase is linear with scale-up. In low-income countries, we see very substantial gains once the scale-up levels reach 60% or more. Now, the estimated lifetime return on investment is very substantial. We've estimated these to be for incremental cost around $232.88 billion in the period 2020 to 2030. This means a 6.9% increase in the current global cost of cancer treatment and care. But the lifetime productivity gains are staggering. They're 2.89 trillion. This produces a net economic benefit of $2.66 trillion. For the world as a whole, on average, the return on investment is $12.43 for every dollar invested. This is for comprehensive scale-up. If we were to scale up just treatment and quality, the returns would still be very large, 1.16 trillion, but the return on investment would decline from 12.43 to $6.15 for every dollar invested. As you can see from this heat map, in every single country, there is a net return on investment and very substantial returns on investment for every country and for every territory of the world. So we present a very compelling case for the first time that there is a substantial benefit in both health terms and economic terms. In health terms, averting deaths and also improving survival, 5-year net survival, and economic benefits by demonstrating a very substantial lifetime gains in productivity and the net benefit for every dollar invested. Now, we get benefits by investing in imaging alone, but also imaging combined with treatment, as well as combined with scale-up of surgery and radiotherapy and quality of care. But the substantial benefits are realized when there is comprehensive scale-up of all of these interventions. So there's no doubt, based on our modeling, that investing in imaging for cancer is highly desirable with substantial health, economic, and societal benefits. But where will the money come from? Well, if you analyze fiscal space that might be available to countries to scale up imaging for cancer and other interventions, there are multiple sources. The first source is from improvements in the economic conditions. Now, for low and middle income countries, economies are growing. In spite of COVID-19, economies are growing. This will lead to increased investment in health systems, and part of this funding can be channeled into cancer and imaging modalities for cancer. This is feasible, and the sums would be substantial. The second source is reprioritization of the government budget to health. Now, in theory, this is feasible, but in practice, politically very difficult, because each of the other ministries would wish to have funds allocated to them, and rather than giving up funds to other ministries. In any case, the sums realized may not be very substantial. The third area is sector-specific domestic revenue sources. In practice, this means targeted taxes for alcohol, for tobacco, and other interventions that lead to adverse effect on health. Again, just for tobacco tax, we've estimated that the gains would be very substantial. And many countries, such as the Philippines, they've used these funds to finance their expansion of universal health coverage. So this is a feasible source with huge health and economic benefits, and the sums raised would be very substantial. The fourth potential source for expanding fiscal space is international finance, borrowing to invest. As we've demonstrated, we are no longer talking about expenditure on health, but we're talking about investing in cancer treatment, prevention, treatment, and control. And there's a compelling case for borrowing to invest because the health and economic benefits are very, very substantial. And currently, borrowing costs are relatively low, given the low interest rates. The fifth source is improvement in the effectiveness and efficiency of the available health budgets and improving the efficiency and effectiveness of health systems. WHO estimates suggest, and other estimates by IMF and others, suggest that around 30 to 40% of health expenditures are wasted. So one could improve the system efficiency and effectiveness, and this is feasible, and the sums realized would be very, very substantial compared to other opportunities. The sixth and final potential source is innovative financing. For example, by providing export guarantees or social impact bonds or development impact bonds or novel approaches that involve the private sector to invest in health sector and in expansion of imaging diagnostics. Again, this is feasible. Many effective models exist, both in the health sector and elsewhere, and the sums would be very substantial. So, dear colleagues, what our study and the new Lancet Commission and Lancet Oncology Commission demonstrates is very substantial returns on investment in imaging for cancer treatment. The benefits in terms of health, as well as economic benefits and societal benefits, are very substantial. And there's a compelling case for investing in scale-up of imaging diagnostics for cancer globally. Thank you very much for your attention.
It is a great pleasure and a tremendous honor to be a part of the Lancet Oncology Commission on Imaging and Nuclear Medicine, and to present an overview and recommendations. To begin with, I'll need to start with my disclosures. I serve on the Board of Directors, IBA, External Advisory Board for Johns Hopkins, International Advisory Board for University of Vienna, and on Scientific Committee and Board of Trustees for DECA-FSE. This commission is a result of a large number of authors, commissioners at large, and individual contributors from all over the world. We came from all 6 continents. To give you an idea of the number of participants for the commission, here is the list of the authors, list of the commissioners at large, and individual contributors. Obviously, the number of people involved in this commission is huge, and from the bottom of my heart, to each and everyone, thank you. We all were moved by the fact that 80% disability-adjusted life years lost to cancer in low-middle-income countries, and yet only 5% global funding for cancer control and care occurs in that region. There are a number of outstanding programs through universities, private and public sectors trying to make a difference. However, currently, there is no clear overarching global strategy for scaling up cancer imaging diagnostics across low-middle-income countries. So perhaps this is the reason that not only so many individuals, but so many societies, institutes, organizations, and foundations join this commission. Cancer care is a team effort, and the societies and institutes that join are not only from radiology or nuclear medicine, but joined a medical societies such as ASCO and ESMO, radiation oncology such as ASTRO, and then aortic, which is an African society for education and research. I would like to take this moment and say a big thank you to IAEA and especially to Dr. May Abdel Wahab, Director of the Division on Human Health Development. Her involvement in this commission was absolutely essential and much appreciated. Our efforts align with 2017 WHO Cancer Resolution on cancer prevention and control in the context of an integrated approach. Among the shared goals are increasing access to affordable, safe, and effective diagnostics for cancer care, and supporting UN health targets in the 2030 Agenda for Sustainable Development. There are many achievements in this commission. To name a few, for the first time, we have global data collection on imaging and nuclear medicine equipment and workforce as presented by Dr. Andrew Scott. For the first time, we have evidence demonstrating the substantial health benefits of scaling up imaging and nuclear medicine access for cancer patients globally. And then a very compelling economic case for further investment in imaging and nuclear medicine as it was just presented by Dr. Rifat Atun. So when we look at the return on investment in a comprehensive scale-up of treatment, imaging, and quality of care for low and middle-income countries, for every dollar invested, if we scale up only treatment and quality of care, the return on investment is $6.15. But when we went imaging, then that return on investment more than doubles. And this is a story that we need to tell everybody, including government and different agencies, so we can succeed implementing our recommendations. So what are the next steps? So recommendations for policy and investment in low middle-income countries include imaging diagnostics must be a part of essential benefits package when expanding universal health coverage. National cancer control plans must include actions for scale-up of cancer imaging and diagnostics if they want to get the best return on investment and health benefits. There has to be increased capacity of imaging equipment and workforce. We have to foster and develop collaborative networks of imaging diagnostics specially designed for low and middle income countries. Workforce development will be challenges, but through investment in education and training, we can do it. And of course, we have to invest in R&D to foster innovations in affordable cancer imaging diagnostics that can only be done in the low and middle income countries. Target? Well, implementing our vision requires courage and boldness. One of the targets we set for is that we should establish a $100 million fund dedicated to cancer imaging diagnostics in low middle income countries by 2025. We don't have much time, but considering the results on the health and economic benefit, we think it can be done. And then, of course, furthermore, the target is to mobilize and invest $25 million thereafter. This way, in a comprehensive approach, we will make the difference. But to tell the truth, Now the hard work begins, which includes dissemination, advocacy, and implementation. We have to together ensure that Commission findings are implemented. And not easy, challenging, but possible, we have to address all stakeholders needed to take action, and that includes from governments to private sector and civil societies. As we do all of that, let us remember, please, we're going to be inclusive, we will be persistent, and we will stay united. So with this in mind, thank you in advance for being the change needed. Thank you very much.